Hi, I'm Dr. Sri Ganesh from Netradama Super Speciality Eye Hospital, and I'll be posting videos almost every week. Some of them are teaching videos and some are interesting cases that I have done. And if you like my videos, hit the like button and press the bell notification to get notifications whenever I post a video. Rock-hard intumescent cataracts pose a challenge to the cataract surgeon. There are various challenges in these cases. One is doing the capsulotomy itself, because there's a very high risk of runoff in an intumescent cataract. The second is the capsular bag itself is very weak, so you'll have to be careful about the maneuvers, and the zonules may be weak. The dense cataract is very difficult to crack, and the fibers are very leathery, so it may be difficult to crack the nucleus using any kind of technique, whether it is stop and chop or a direct chop. And in these situations, some new equipment may help us. I'm showing you a video of a case which I did this week. It was an intumescent, very dense grade 6 cataract, where we attempted to use the femto, but then with the femto again there are a few challenges, in the sense that when you make the capsulotomy may not be complete, and you may have tissue tags which can cause a runoff. So you have to be very careful. You'll have to stain the capsule with trypan blue and then use a forceps to complete the capsulotomy. The nucleotomy does not penetrate, and so you do not have any incisions on the nucleus in dense opaque cataracts. And in this case, we have used a device called the MiLoop. The MiLoop is made of nitinol and has an accentuator. It is being marketed by Carl Zeiss Meditech, and this instrument greatly helps in cracking the nucleus. Nitinol has a very good memory and is super elastic, so it can take a shape and it goes around the nucleus, and we are able to crack the nucleus very comfortably, even the densest cataracts. And this considerably reduces the manipulation and also the amount of phaco energy used. It avoids complications like wound burn and corneal endothelial damage, and these patients do very well. In fact, we have seen that the phaco energy is almost less than 50% that of conventional phaco, and in such cases where the femto does not act, it is a boon. You can see that this is a very dense intumescent cataract. Femto has been done, incisions are made, and trypan blue is inserted into the chamber and washed out. You can see the flap floating, and then the flap is carefully removed with the forceps so as to not create a runoff. Then a gentle hydro is done, and the nucleus rotates very freely. You can note that there is no nucleotomy which has occurred with the femto. We put in a good dispersive viscoelastic into the anterior chamber, viscode. That is the MiLoop device, which has a nitinol loop and the accentuator for opening and closing the loop. The loop is closed and it reduces to 1.2 millimeters, and this is inserted through the wound just under the anterior capsule, and you see that the black mark is at the wound. Then the loop is rotated. You can see the silvery reflex going behind the nucleus. A second instrument is used to support the nucleus as you close the accentuator to prevent the inferior pole from tilting up. This is a very dense cataract, and you can see that it is cut easily into two halves. Then again the nucleus is rotated through 90 degrees, and the MiLoop again is inserted to encircle the nucleus. The second instrument is introduced, and the accentuator is closed to cut the nucleus now into 4 pieces. These 4 fragments are then easily emulsified with the phaco probe, and you can see that there's hardly any cortex. Minimal IA is done. Sometimes you have some cortical remnants in the fornix of the capsular bag, so I use a 27 gauge cannula and BSS to flush out these remnants of cortex, and then the IOL is introduced into the capsular bag. You can note that there is no wound burn and the cornea is crystal clear and very pristine. The phaco energy is considerably reduced to less than 50% when you use the MiLoop device. That's the end of the surgery, and we open up the arcuate incisions for correcting astigmatism made by the femtolaser. And you can note that the CDE in this case is about 17.7, and the patient did very well. Thank you.